Okay, so welcome everyone to our third session on the intersection of reproductive health and substance use disorders. Today we're focusing on interventions or initiatives at substance use treatment or recovery settings. And this is presented by the Center for Public Health Practice and the Center for Health Outcomes and Policy Evaluation Studies at The Ohio State University. I want to acknowledge the many partners that we worked with to come up with the agenda for these sessions, and they are all listed here. And then just some housekeeping technical information before we move along. The sessions are recorded and they will be emailed and posted on our website along with the slides. All the participants are automatically muted and video is disabled. I can allow you to speak if you want to clarify any questions you might have. Just let me know in the chat function. There's also a Q&A function that will help us ask any questions to the panelists. And if you have a specific question for someone, please identify the person you're addressing in the Q&A, and then we will ask the right person. For this session, I think we'll have plenty of time to do Q&A after each presentation. So I'll leave about 10 minutes for each group of presenters to field questions. You can also use the chat function if you have other questions related to this series or our center or any technical issues you might have. And finally, we are providing CHES credits and social work credits. You must complete an evaluation that will be emailed after the session is over, and we will process the CEUs in December when our series is over. So here is our agenda for today. We'll have Syra speak first. She's a colleague of mine from HOPES, and she's also on the Ohio Policy Evaluation Network. And then we'll have Karen, following that, Joe Taylor and Alex Meyer, and then finally April and Brittany. So now I'm gonna stop sharing my screen and I will let Syra just give a quick opening and welcome and then talk about the policy network.
Hi, thanks so much, Anne. I'm gonna go ahead and share my screen. It probably won't be relevant until a little bit into my introduction, but as Anne said, just welcoming everyone here today. It's very nice to join you all for this educational session that explores the intersection of reproductive health access and substance use disorder. As Anne said, my name is Syra Nawaz, and I'm a research evaluator at the Center of Health Outcomes and Policy Evaluation Studies at The Ohio State University in the College of Public Health. My primary role has been to support this idea of evaluative thinking, which to me means understanding what we can learn about the performance and effectiveness of policies and practices from the data that we have, and also where better data and better information can be collected as opportunities to learn more. A project that I do work on is the Ohio Policy Evaluation Network. And the role that I play is as a big data analyst using existing public and private data sets to understand various aspects of contraceptive access in Ohio as well as nationwide. So what I've projected on the screen is a starting place for our development of a data dashboard that's going to explore various metrics that are related to contraceptive access, specifically for Ohio, and gathering county level indicators that will give us some more information about the context for contraceptive access. You can see from our data page, we've got a lot of data elements that we're trying to integrate so we can get the most holistic understanding of what factors influence access to contraception, and at, I would say, a more detailed geographic level. What we found is that it can be challenging to really quantify and characterize the disparities in reproductive health access for individuals with substance use disorder. And so what we are trying to do is use healthcare claims data to explore the extent of these disparities and explore whether and by how much state efforts in terms of policies and programs can begin to perturb these trends and really create change and minimize disparities. This is where I think evaluative thinking comes in. So we're not just, quote unquote, studying the disparity or reporting the disparity, but really trying to unpack what is working, why, and try to figure out a good platform for sharing that information with policymakers and the public alike. And so this is kind of our attempt to try to bring all those pieces together and really explain why not looking at a single piece of information, but really gathering the information and presenting it in a way that's digestible is important to understand the access issue in Ohio. So I'm going to stop there and pass it back off to you, Anne.
Thank you for that overview, Saira. And if anyone has any questions for Saira, you can go ahead and put it in the Q&A. I think Open is a really good data resource for impact evaluation, and I hope that we can work with a lot of you if you're starting to think about new initiatives to make sure that we build in a good evaluation plan for those initiatives. Okay, so I will stop sharing my video to minimize the Wi-Fi needs, and I will let Karen introduce herself and then start her presentation. Go ahead, Karen.
Okay, hi, I'm gonna just start by sharing my screen. One moment.
Looks good.
Okay, great. So thank you so much for inviting me to share this quality improvement project that I conducted during my Doctor of Nursing practice degree at Arizona State University. I'm a nurse. I've been a nurse for over 20 years, and I've always done direct care with women and infants. I'm particularly interested in reproductive health and contraception, as well as lactation and breastfeeding support. I find myself enjoying helping women where things are a little more nuanced and guiding them with evidence to make the best choices that as they see fit for themselves. So it was exciting for me to get involved in this area of reproductive health, which was using a pregnancy intention screening tool called One Key Question to support women in recovery. So with that, I'll start the slideshow. So the problem that this project addresses is that, as we know, women with substance use disorders face barriers to accessing reproductive health care, and therefore experience unintended pregnancy rates nearing 90%. So unintended pregnancy rates can have serious consequences for women in recovery. She's at increased risk for many things, including this list here: high blood pressure, postpartum depression, suicide. Also, her baby is at increased risk for many things, including fetal alcohol spectrum disorders, neonatal abstinence syndrome, which is newborn withdrawal, and family separation. So contributing factors include threatening policies that have increased stigma, reduced funding for family planning, and a siloed healthcare system. We're really all called to action to address this problem. The American Academy of Pediatrics and the Centers for Disease Control and Prevention are calling for prevention strategies to reduce neonatal abstinence syndrome. The American College of Obstetrics and Gynecology is recommending that we increase contraception counseling to women with substance use disorders. And the World Health Organization addresses this issue with an emphasis on autonomy when having these conversations. Also, the Substance Abuse and Mental Health Services Administration, better known as SAMHSA, has been recommending that and promoting integrated women-focused recovery programs for over a decade, yet few exist. So to align these recommendations, we really need to increase our collaboration. Crossroads, Inc. is the site where I conducted my project. It is Arizona's largest substance use disorder recovery program. It's been open since the 1960s. It is one of the few programs in the nation that offers an on-site integrated primary care clinic that offers a full range of reproductive health care services. The on-site clinic is called Crossroads 360. It's new. It opened in January 2019. And before that, and before my project, when women entered the residential recovery program, no questions were being asked about reproductive health care needs. So there wasn't much internal evidence before I started, but during my field work, I candidly asked some women if they had any contraception care needs or help with family planning needs. And this was the response of one of the clients. So she told me, you know, not once has anyone ever asked me that. And it's so important. I know so many women who have had babies only to have them taken away. And that makes recovery so much harder. There's no pain like that. So what made her response even more powerful and significant was that this was the 18th program that related to recovery that she was entering. So her response really demonstrated to me that integrating reproductive health conversations in substance use disorder settings is not currently common practice. So I took a deep dive into the literature to see what I could learn. I reviewed these 3 databases with these key terms and narrowed the studies to the 10 most robust and relevant studies. The themes that emerged from that lit search were that that interpersonal relationship between the client and the provider is just of key importance for family planning. That client experience of care correlates with the use of contraception method effectively, as well as the satisfaction with the chosen method, as well as the willingness and likelihood to return to the provider for help as needed to modify things or change methods or just get ongoing help. So educational tools and decisional supports were the most common interventions used. Motivational interviewing was the most common theory used with this population. Reproductive justice emerged as a key theme, emphasizing the importance of ethics when we are designing and measuring quality improvement projects related to family planning. And the importance of that client experience of care, that influenced the selection of my project framework as well as my outcome measurements. The motivational interviewing and reproductive justice themes influenced the theory that I selected, and that intervention that I chose was really based on that need for some decisional support and education. So this is just an overview of the project framework. It's the IHI Institute for Health Improvement Triple Aim. You may be familiar with this already. This model highlights that we cannot make changes with only cost or population health goals in mind, but that we really need to be looking at that person's experience of care directly with their healthcare provider to ensure that we reach our improvement goals. The other thing reason why I chose this one is they have a very simple implementation model of this plan, do, study, act, which can be kind of repeatedly, you can go round and round in sort of an upward spiral towards improvement. And I thought that was really appropriate for a fledgling program that was, you know, for sure going to be doing ongoing quality improvement. So to ensure that the project was congruent with that value in the discipline of nursing, as well as the ethical themes that emerged in the literature, I chose this combined theory. It's called the self-determination theory and motivational interviewing. So like I said, motivational interviewing was established in the literature as being effective with this population, but choosing this combined theory, I believe, strengthens the use of motivational interviewing for family planning quality improvement projects, as it anchors it with that theory of self-determination, which expressly avoids coercion and supports autonomy. This theory proposes that by providing structure with evidence-based information, autonomy, support, and the involvement of an empathetic and understanding provider, we can then use those motivational interviewing techniques to help people make progress towards, you can see at the bottom of the slide, the goals of competence, autonomy, and relatedness, which is essentially feeling connected to a supportive person. So I chose the one key question pregnancy desire screening tool to guide that conversation that I was going to add on to the admission assessment that was currently being done. This tool was developed by the Oregon Foundation of Reproductive Health and is now licensed by the nonprofit organization Power to Decide. It was designed and validated in primary care and other community settings that don't ordinarily talk about reproductive health. So it's purposefully simple, yet it is powerful enough to kind of tweeze out who has straightforward needs and who has more complex needs that may need to be referred for to a reproductive health care provider. It's been widely endorsed and it very importantly equally supports women who want to become pregnant as well as those who do not want to become pregnant by providing follow-up care either direction, whether that's for contraception counseling or preconception counseling or somewhere in between to address their nuanced needs. So of course, protecting the women that participated was key, and IRB approval status was obtained through Arizona State University. This is an overview of the project timeline. It was about an 18-month project as a student that we do from the beginning field work to the disseminating the project. The actual implementation was a 1-month pilot demonstration of using this tool in the month of October in 2019. I used this data collection record and I put it out in front of myself and the client that I was speaking to so she could clearly see the question and the response options and the follow-up questions. Essentially, I created like a second booth after their standard admission assessment. I maintained the fidelity of the one key question training by asking that initial question verbatim, would you like to become pregnant in the next year? And then providing those 4 clear response options of yes, okay either way, unsure, or no. Of course, people were informed that they could decline to participate at all. And for some people, the question really didn't pertain. For example, if they had a hysterectomy. So one thing that I appreciated about the one key question training was that it taught me that you, after meeting that criteria of the verbatim first question and the 4 response options, you can kind of nuance those follow-up questions to best suit your particular setting. So I added, are you aware of the clinic services here available here at Crossroads 360? And I also asked them if they'd had a well woman exam in the next 12 months because that was something we could offer them as well. I then used descriptive statistics to summarize this data and present it back to the organization as like a magnitude of needs and desires. So this is the client experience of care scale that I use to measure that care experience. And I chose to do this measurement because I really wanted to stick to that IHI triple aim, which tells us that we need to be focusing on the client experience of care. It also maintains a focus for me and the other providers that our goal is to be supporting autonomy, providing structure with quality information, and providing sincere involvement. So I used this Likert scale, which is a tool that was adapted with permission and assistance from Dr. Christine Dellendorf of UCSF, her IQFP, which is Interpersonal Quality Family Planning Scale. Her original scale is 11 points, then she reduced it to 4. This one is modifying the 4-point scale. And we also had the input of Dr. Lisa Caligari of the University of Washington helping us with the wording. So the reason why we adapted that original tool that she has validated is that the original tool is designed to measure the experience with contraception counseling, and I needed something for screening purposes that could kind of go either way with preconception or contraception. So the outcomes were that we had a very enthusiastic participation. So we had 83 clients admitted to the program in October. Occasionally women had to go back into the hospital. So on days that I was there, 77 were available. 65 met the inclusion criteria, which essentially was that they were 49 years or younger. There's only adults at the program, so no one's under 18. 63 people agreed to participate, and everyone who started completed, and then 54 completed that client experience of care. So The responses to that initial one key question of would you like to become pregnant in the next year was 69% said no, 16% said yes, 13% said I'd be okay either way, and 2% were unsure. So to simply summarize the magnitude of needs and desires report that I created, 97% of the participants identified a need for reproductive health care using this conversation. And of those, 98% desired that care and accepted the referral. So the frequency of referral types are presented here in this table. The most frequent referral type was for well woman care, representing just over half of the referrals made, followed by contraception care, preconception care, general reproductive health for women that were ambivalent or somewhere in between. And then there were some other referrals that were identified as needs. For example, postpartum appointment was identified. So clients experienced excellent care experiences using this screening process. You can see that we only had a few rate the experience as good or very good, and no person rated any item as fair, poor. So the impact, lessons learned, and the potential impact of this project were, first of all, it really agreed with what I found in the literature that very significant needs and desires exist in this population for reproductive health care. What there wasn't much about in the literature that my project suggests is that screening early in recovery programs is acceptable to clients. Conversations about reproductive health care were very appreciated in this project. And measuring that client experience of care really kept the provider focus on the ethics. And while training is very important for fidelity, the exact type of person that is going to lead these conversations is quite flexible. Doesn't have to be at provider level or even an RN. Multiple role types could do this, which I think is nice. So future directions were, I recommended that Crossroads sustain this program by completely training their staff, incorporating it in electronic health record, and routinely screening on admissions from here on forward. And I hope that by sharing my findings in forums like this, it may inspire other improvements elsewhere. I think it could be implemented very easily at a place that is similar with an on-site clinic, but I also think it could be powerful for places, substance use recovery programs that don't have an on-site clinic, but that take the forethought to plan out their referral system so that they can have a clear referral pathway for partnering clinics. So I've been very pleased with being able to disseminate this in multiple formats. I did a webinar with Dr. Thompson to LA County to help with their their program, which is similar. I presented to a subcommittee of the National Contraception Measures Work Group, and together with Mackenzie Piper of Power to Decide and Dr. Thompson from Baltimore, who did a similar project out in Baltimore, we are going to present these findings at APHA this fall. So in conclusion, I didn't set out to plan any or to collect any qualitative data, but all of the women who participated in the initiative took the initiative to write comments in the client experience of care scale. None of the comments were negative, and I'm just going to share a few of them here with you. And I kind of like reading them aloud because somehow it also mirrors how I feel about this project. So each color is a different woman's voice, a different participant's voice. But so these are some of the things that the women said. They said, I feel very happy with the information I now have that I didn't have before. Programs like this should be put into place more often. Thank you so much for listening to me. Thank you for letting me say what mattered. And I'm so glad you came to see me. So with that, I'll just flick through my references and then turn it over to question and answer and the next speaker.
Thank you, Karen. I have some questions just for myself, and I just wanted to share with participants that Mackenzie Piper from Power to Decide is also a panelist. So if you have any questions about potential partnerships there, she can field your questions along with Karen. But Karen, I have two questions. One, did you follow up with Crossroads to see if any of those recommendations were implemented? And two, since you've done this work, I wonder if you've had any special outreach to syringe service programs, because in Columbus, we tried to find funding to work with our syringe service program to implement one key question as a way to make a connection with those participants to introduce them to women's health. So did Crossroads implement any changes that you recommended? And have you considered working with SSPs?
Okay. So let me address the Crossroads first. So I think they will be incorporating this. I know as of just a couple weeks ago, they had a big leadership change. So I think some of the things are on pause, and of course, COVID didn't help too much. I graduated in May. So, you know, they got to hear all this report like over Zoom in May, and then they've had a leadership change. But we do have a strong connection. Arizona State University and Crossroads has a strong connection. So there's really tight relationship there with ongoing quality improvement projects. And some of our faculty are still working there. And we have a student in a similar role to me, but like a couple years behind, who plans to take this baton and go with her DNP project to try to take it to that next level of probably working out those organizational challenges of how to
totally,
which is exciting. So I think that community partnerships are really important, and ASU is part of something called SHOW here, which stands for Student Health Outreach for Wellness. And that is a multi-university program through just the state of Arizona. So it's all our big state schools, as well as other schools that do volunteer work to serve underserved populations. So Arizona State is part of SHOW, and SHOW has a strong ongoing relationship with Crossroads. So that really helps that organization implement these changes.
Yeah, I really like the idea of building the process into the EHR. I think that's very smart.
Yeah, absolutely.
Mm-hmm.
And then clarifying for me again what your other question was, or did I?
Have you considered working with syringe service programs to also implement one key question as a way to initiate conversations with those participants around reproductive health?
And I'm not sure I'm familiar with the SSP, what that means.
Oh, yeah, sorry. That is a syringe exchange program for injection drug users.
Yeah. No, that's great. That's such a great, I'm so glad you brought that up, because one of my ASU colleagues she got involved with an SSP program. She was doing something unrelated to reproductive health, but more wound management. But she has now been hired at Crossroads. There's, how everything kind of overlaps like this, but she and I have talked about that being a really great potential for this kind of intervention. I think that's an excellent idea. I myself have not become involved with any of those projects, but that has a great potential. Absolutely.
Okay. And I guess I just have one question for Mackenzie. From the Power to Decide organizational standpoint, have you reached out to any syringe service programs, Mackenzie?
Hey everyone, thank you for first letting me listen. Karen, I know I've heard your presentation a few times, but it's always really good to hear it. So thank you for lifting up one key question, but also lifting up this intersection of family planning and substance recovery. So to answer your question, Anne, we haven't made any direct contacts yet with syringe programs, but I see this kind of field being ever growing, and this intersection ever growing. So if any folks on this call do have a connection there and a space that we can kind of enter and partner with you, please reach out. So the invitation is open.
That's great. All right. So we don't have any questions that came in yet, but when they do, Karen, we will wait for the next presenters and then move them to you to address if they come in. But for now, I will turn it over to Joe Taylor and Alex Meyer. They have a partnership between Columbus Public Health and CompDrug, and you can go ahead and share your screen and get started.
Okay. Can you see my screen?
Yes, we see your screen. Great.
Okay.
Mm-hmm.
All right, so good afternoon. To introduce myself, I am Joe Taylor. I am a nurse practitioner, and I have been working in the field of reproductive health for about 20 years. I'm currently the clinical administrator at Columbus Public Health, and I oversee the Women's Health and Wellness Center, which is a Title X federally funded family planning center, and we get support from the Ohio Department of Health. So I'm here today with Alex Meyer, who is my partner in this work, and we are here to tell you about our project integrating women's health with substance use disorder at CompDrug. So I'm going to go ahead and let her introduce herself as well.
Alex, you're muted. There we go.
Sorry about that. So Joe, thanks for turning it over to me for the introduction, and thanks for having us today. We really appreciate the opportunity to talk about this partnership and great project which we've been doing together. So as Ann said, my name is Alex Meyer, and I'm with CompDrug. We're a large opioid treatment provider in Columbus, Ohio. I'm the chief operating officer there, and prior to working with CompDrug, where I've been for the last 5 or so years, I was at Nationwide Children's Hospital working in the area of neonatology, and became very involved in a program related to reducing rates of neonatal abstinence syndrome, and working closely with both women, pregnant women, and their children, which is then how I got linked into that connection between working with women who are pregnant or seeking to become pregnant and the substance use world. Joe, back to you.
All right, so first I just wanted to tell you a little bit about my department. So Columbus Public Health is the local health department for Columbus, Ohio, which is the 14th largest city in the United States, and also the city of Worthington. It's led by a 5-member board of health. There's about 500 staff here. There are lots of public health programs and several clinical health programs, one of which is the Women's Health and Wellness Center that I mentioned. Our main campus here, you'll see that picture, it's at 240 Parsons. And there are several satellite clinics out into the community in different places. One thing I wanted to mention is being a Title X family planning program, that program really prioritizes services for either low-income individuals, maybe families that don't have insurance, or those that desire confidential services. So I did want to mention that's the program that guides us and also funds our program and allowed us to be a part of this project. And I wanted to talk a little bit about how this work started, and Alex mentioned it, but our biggest partner for both of us really is the Ohio Better Birth Outcomes, or we refer to that as OBBO. And OBBO is a community partnership of the hospital systems, the federally qualified health centers, and also Columbus Public Health. And so you'll see our main partners there along that right-hand side of the screen. But OBBO is a collaborative dedicated to reducing infant mortality in the county by improving the delivery of healthcare. And it's really, it uses a quality improvement approach or framework. So we set interventions, we test them, we create goals, And OBBO is really focused on 3 key initiatives. So improving reproductive health, this is the work group that I'm most involved with, expanding access to prenatal care, and reduction of prematurity. In 2017, the collaborative work between OBBO and the partners shifted somewhat. So when we were brainstorming and thinking about people that maybe we haven't yet reached, or what else could we do based on the infant mortality rate, the conversations really changed to addressing infant mortality in the context of substance use disorder and treatment. And so it's with the support of OBBO that this effort and this project really came to fruition. And we continue to receive a lot of support from OBBO, and they have been a great partner for us and really have helped us see this through. So our strategy came from a report that now seems outdated, but it was several years ago, that concluded offering reproductive health services in substance use disorder treatment as a potential way to decrease unplanned pregnancies and improve the overall reproductive health of women in treatment. And since then, there is a lot of support in the literature that the lack of reproductive health care for women in treatment is really a missed opportunity. And this is what led to the opening of a Title X or reproductive health center within CompDrug, the treatment facility there. So all of this work really overlapped. So what Alex is saying, the infant mortality work, and we felt here at Columbus Public Health that we were really perfectly positioned as a Title X health center to be able to do that. And I would say our biggest, what has really led us to the most success is the partnership here. And I'm gonna let Alex talk, of course, about CompDrug, but what I always like to say when we talk about this project is that all of the partners, so CompDrug and the staff that we've worked with there, and OBBO and all of their staff and support, we really all had this all-in mentality. So when we all came to the table together, and we came together many times before the project started, there was nobody that said, no, we can't do that, or no, that won't work. It really is a group of people that are dedicated and we're willing to really do anything to see it through and make it successful. Alex, I'll turn that over to you to talk about CompDrug.
Thanks, Joe. And I would definitely echo those comments that you just made. It's really been amazing what a great partnership and collaborative it has been, and part of truly why it's been so successful, as you say, is that we were all in it across all the different organizations. So CompDrug, we are based in Columbus, Ohio, as I mentioned, and we are a large substance use provider providing entirely outpatient-based treatment. So we're specifically licensed as an opioid treatment provider, which means we're focused on providing support and treatment for those struggling with heroin addiction and those struggling with prescription painkiller addiction. And we are one of the largest opioid treatment providers in the state of Ohio. So we currently have a census of about 1,200 patients, and half of those are women. So that was another part of why this was such a great opportunity. We have 700 women who could benefit potentially from this service offering. What we know as an opioid treatment provider is that we see our patients as frequently as daily, or at minimum once every 2 weeks, which is still fairly frequent. So as such, we really are positioned to see our patients more than any of their other healthcare providers. And that gives us, as an opioid treatment provider, great opportunities to serve not just their addiction concerns, but their a patient's overall health needs. So we're able to focus on the addiction, help with health needs, and in improving overall health, that in turn assists the patient in their recovery. So having these services embedded on site has been critical. We recognize that co-location of services allows ease of participation for women. It really improves convenience and reduces barriers such as transportation. So it's just been incredible to have this clinic based on site. Joe?
So we had a rather extensive planning, I would say. It was about 6 to 12 months, which in hindsight seems like a long time, but we really wanted to get this right. We felt like it was important. We wanted to gain trust. We didn't want to have a misstep if we could prevent that from happening. And so some of the early things that we did, I know that the CompDrug staff had contraceptive counseling, which we felt was important. We had to get permission to extend our Title X services from the Ohio Department of Health, who fully support this work and continue to do so. There was a conversion of office spaces. So there was a space that was identified at CompDrug that was currently being used as office space. And so there was really some minor renovation that needed to happen. We wanted to create unique marketing materials. We wanted the marketing materials to feel very special. And so we'll talk about that in just a little bit. And then we conducted a preliminary survey of the female clients. Would you be interested in these services? What day would be best for you and what time? And then another big part of our planning was really to establish a shared goal or a shared vision. And we did that early on. And I do think that was really critical to the success of our project, because sometimes we had to come back to that as we either added services or changed things. But our goal was an on-site and integrated reproductive health clinic within the treatment facility. And we also felt at the time it was the first of its kind, so that was also important to us. Here's a look at the actual physical space. Our clinic opened in February of 2018, and it runs weekly for half a day on the day that the women chose, which was Wednesday. So we have 2 rooms. So we have an office for intake. So you'll see that on the left. And then we have an exam room that looks like any exam room you'll see in any gynecology or family planning office. Our staffing model here at CPH for the project is a nurse and a nurse practitioner model. And I am the provider at this project. And then one of the things that we thought a lot about was women that are receiving their daily, or any of the clients at CompDrug that receive their daily or weekly dosing and treatments, they do that in another building that's very busy. So you heard from Alex how many people they serve. And that building really kind of buzzes, and it can be noisy at times, and it's, we were very thoughtful about the fact that we didn't know that that was the right environment for someone to have a gynecologic exam, or for someone to talk about things like reproductive life planning. And so there is a separate building next door to the main building at CompDrug that houses our clinic. And it's a very nice building. There's a lot of counseling that happens there. There's classes, there's yoga. So this is still a building that all of the clients of CompDrug are in. So it's a familiar building. It's within walking distance. They walk across the street. But it's a very peaceful place. So we were deliberate about that as well. We used a variety of materials and strategies to promote our services within the facility. So you'll see that here. We've developed brochures and posters. There is an electronic lobby display at CompDrug. And so the nurse and I that are there at CompDrug, we have our pictures and our bios, just like the staff of CompDrug. There are electronic monitors. We used a sandwich board between the 2 buildings just to remind people on the day that we're there, hey, we're here. Be sure to come and see us if you'd like to. And then in that main building that I just talked about, for several months, one of our OBBO colleagues would go to the lobby and, you know, just meet with people, talk with them, hand out a card, remind people that we were there, and talk about the services. So that was a way that we really spread the word about our services in the beginning. We also, I know that the services that have been featured a couple of times in the CompDrug newsletter as well. And then we did get some help with focus groups, which I'll talk about in a minute, and some marketing support from OBBO and Nationwide Children's. And it was really eye-opening. But one of the things that we looked a lot at was our marketing materials. And we have redone these all one time. So we got feedback from women that they didn't like the marketing materials. And so we recreated those and they were all refreshed, and people really liked that. The clients liked that. They felt like they were a part of it, and that their voice really mattered when it came to not only the services, but some of the promotion. So the marketing materials and the promotion have really evolved over time, and really that's because of feedback. And then that may be a little hard to see, but our main brochure there, those points that, some of those points that are listed came directly from women and what they really needed to hear to feel good about visiting this clinic. So things like a need for a female provider, we heard that a lot. A highly qualified and credentialed person. So they wanted to know what are your credentials? And they asked me that a lot, which is a good question. Confidential. So they wanted to know that what they told us and what services they received stayed with us. What services outside of contraception were we offering? And that was a good lesson for us too. So we tried to focus on birth control in the beginning because we felt like that was easy for everyone to know what that service was. But we heard from the women we needed to be more comprehensive, and that was a less judgmental message. So some of those focus groups and feedback was invaluable for us. We've held different educational sessions, and we feel like they were an important way and continue to be a way to engage with the CompDrug staff, not only the clients, but also the staff. And it really helped us get some buy-in, especially for people that may not be familiar with reproductive health. And so you'll see we had two approaches, staff training and also client education. And so we've done a variety of things. The staff received contraceptive counseling. We've attended staff meetings. We've had some really good one-on-one discussions with counselors and nurses. We did play bingo, which everyone really liked, but that of course led to some really great discussions. So you'll see our bingo, one of our bingo cards there. And then in terms of engaging with clients, we have just found the more that you can do that, the more that they see you, that they see your face, that they can have a discussion even outside of their visit with you, the better it is, the more that they trust you. So Ask a Nurse is a regular group at CompDrug where they talk about many, many things, not just reproductive health, but I've attended that myself multiple times, 5 or 6 times. Counseling groups, just having a presence, so being there on a regular basis. And then we also sometimes do vaccination clinics. And again, we're not offering reproductive health services, but we're engaging with clients and we're able to talk about other services or sometimes just meet other needs. Maybe someone needs a different service at the health department that I'm able to talk to them about. But anytime that we've offered an education or had some kind of an event, it always results in an increase in the amount of clinic traffic. So these things are really valuable. And for me as the provider, I learn a lot when I engage with both the staff and the clients. So I really find it to be an important part of the project. I wanted to tell you a little bit about our focus groups. So as I mentioned, we hosted 3 focus groups with OBBO for the women in treatment there. And we learned a lot. Nearly all of them supported the on-site clinic. It led to the change of marketing materials, like I said. It also led to us using more comprehensive language, not just talking about birth control. But we also got a lot of valuable insights and considerations from women talking about their past healthcare experiences and what their experiences with birth control really were and how we could address those and just their other healthcare needs. And then on an ongoing basis, when we think about evaluation or hearing from clients themselves, we do give everyone a patient satisfaction survey. And most of those have been really overwhelmingly positive. I can give you some of the comments that we've heard. So I have a 2 and a 3-year-old, someone said, and can't afford to get pregnant so fast again. You guys are really special to do this. This is easy, somewhere we can come and be helped. Love coming here, things like that. And I will say, one week we got a comment that said, addicts can be good parents too. And that really caused us to take a pause and think about our messaging and think about preconception health and things like that. That is also a service that we offer. So just making sure that we were balanced in our approach. And I think if you've worked in reproductive health a long time, that's something that, you know, you always need to check in with yourself and check in with your staff to be sure that you're really offering that balanced approach. So that was great. Many people may see that comment as a negative. We were very happy to get that comment. And it's something that sometimes we come back to when we're trying to see if we're on the right track. So our accomplishments, this is about 24 months worth of data because our project there has been on hold because of a water main break. So we hope that we'll get back there soon. But this is what about 24 months of data look like. And remember, we're open half a day on Wednesdays. So we completed 184 visits. 69 women obtained a same-day birth control method, 27 of which were a LARC. And then we offer, of course, lots of other services, cancer screening, pregnancy testing, vaccinations, like I mentioned, and then problem visits. We heard a lot from women that it had been a long time since they had a women's health or a reproductive health or woman exam. So that there are a lot of things that they had put on the back burner, things like breast masses or maybe an abnormal pap. And so getting to address those was something that really helped to decrease stress for women. And so we were happy. We have a lot of clinical success stories like that. And it does take time to build trust. So these visits may look low, but sometimes women have to come in a couple of times and talk to me or talk to my nurse and meet us and really establish some trust before they're ready for a visit. We've learned that there are some unique considerations when serving women in treatment, and it's important to work on understanding unique consequences. So many of the women that we're serving at CompDrug have a history of physical, mental, or sexual abuse. So something like a PAP or a pelvic exam can be traumatizing or potentially triggering for women. So, you know, as a provider, you have to think outside the box. Again, maybe that person needs to meet with you multiple times, or just ask what would make you comfortable. Would inserting the speculum help you? Would a support person help, or maybe someone from the staff? I think too, you have to have the right staff there. You have to have people that are patient and willing to work with clients. And then in our focus groups, we heard loud and clear that women with substance use disorder experience a great deal of stigma and mistreatment. We heard stories about people being denied pain medication during delivery or in the emergency room when having a medical emergency. The perceived judgment when having to explain to a new provider that they have substance use disorder. Basic healthcare needs going unmet because they were afraid to talk to people. And then one woman described what she called the look when she went in for prenatal care and had to tell a new doctor about her substance use. And so, like I said, a lot of patients spoke about unmet medical needs, and one person even said, nobody cares because they think that I just want drugs. So while we see that there is a lot of distrust and we hear the stories, what we learned and what's a positive, is that the women really trust the treatment providers, the counselors, and the nurses and the staff at CompDrug. So there's very strong bonds. And one of the things that we learned, and even someone said they are family. So one of the things that we learned was to really partner with them. And if we were having trouble with something, to go to them, ask their opinion, engage with them. But anytime that we did that, we saw a big increase in our numbers. And in particular, there's a counselor that we work with there that will oftentimes bring his whole group over, whether it's to talk about a hepatitis vaccine or another vaccine, but just him endorsing us and endorsing our services really helped. And we've learned lots of other things. Walk-ins are key, so you have to be very flexible when it comes to the scheduling. 95% of the visits we completed were walk-ins and not pre-scheduled. And some of that's transportation, like Alex mentioned. And sometimes they're just trying to get to that yoga class at CompDrug that they really like. But there's a lot of competing priorities. Excuse me. And then confidentiality, I mentioned before, but we found sometimes women were reluctant to leave a urine sample for us when we were testing for pregnancy or something else, because that they thought that we were drug testing them. So talking about how the two programs, even though we're working together, the medical care is completely separate, as is the and everything is confidential was important. Zero repercussions. So there is structure in the treatment facility that is different for us. And so we sometimes had to make clear that that was not the case. And I'm referring to missed appointments. So it's okay if you miss your appointment. It's okay if you don't come back when we talk about you should return. And you know, sometimes we say things like, it's okay if you miss 10 appointments, we'll still see you on the 11th. So that's a little bit different. So you may need to stress that you'll still see people even if they miss an appointment. And then expecting and acknowledging triggers. So we don't always know what a trigger will be for someone, but just to be careful. We've heard from patients that they don't like birth control because it may make them gain weight, which may trigger them to use again. And certainly there's a lot of thought that needs to go around drawing someone's blood. And I found that the best approach is just ask someone, what would make you comfortable when we draw your blood? So for some people, it may be not seeing anything or some strategic taping. And for another person, it may be that they hold on to some of the equipment or something, or they have control over what's happening. So those are things to think about. And then I talked about how messaging and branding really matters, and that can be a misstep that you'll have to address. So next steps for our project, we certainly want to restart services. It sounds like we're pretty close. So hopefully in the next month or so, we'll be able to restart services. And then further integration. So we've talked about how to embed ourselves even more into the culture in the program at CompDrug. So possibly women getting credit for coming to an education or support group. Adding a question into the intake process, when was your last women's health appointment? Just so that that conversation can start very early in the process. And then including it into the treatment plan, which I think Ann mentioned. So we've talked about all of those things. And then there has been replication, and so we hope to continue to do that with OBBO, but there is what we call an OBBO formula, which is many of the successful steps that I've listed here. But some of our other OBBO partners, such as Ohio Health and also Primary One Health, has offered some reproductive health services within other treatment facilities that are local, like Amethyst and Maryhaven. So out of this work came this blueprint, which this is what it looks like. This is the OBBO formula. But the strategy of connecting women in treatment or in the justice system with a women's health care provider for reproductive health. And so you'll see most of what I've talked about there. So on-site medical services, staff training, client education, case plan inclusion, and then marketing and promotion. And then finally, I just wanted to share a story that someone shared with us, because I think that for us, this kind of brings everything together. But a woman shared with us that at 12, she was forced into sex trafficking by her mother. And in the years that followed that time, she had 5 children, closely spaced, and began using substances herself, like her mother. And now in treatment, she came to see us for her annual Well Woman and a same-day contraceptive implant. And so she told us that taking care of her own health and being able to make those decisions for herself made her feel empowered, in control, and hopeful for the future. But honestly, we have many success stories like this, or we hear a lot of feedback that's similar to this. And it seems to be a positive, and Alex can speak more to this, but a positive part of treatment to make decisions about your health care that make you feel good, or that maybe address something from the past that you haven't addressed in a long time. And so that's what we see a lot with the people that we serve at CompDrug. And then there is our contact information, and we're happy to take any questions.
Thank you, Jo. I do have a couple of questions in the queue. So the first one is, I think, to both Jo and Alex. Are there any efforts to screen for human trafficking? Or to screen for someone who might be a victim of human trafficking?
So I can answer that, and I'm sure Alex can too. So we absolutely always screen for human trafficking. It is a vital part of a Title X family planning program. And so we absolutely do look at behavior, risk factors, red flags. We do, yes.
Okay.
And I would just add that we do that as part of our treatment as well. So if a woman is seeing Jo in the health clinic, she's also had that conversation with her counselor.
Okay, thank you. Someone is asking me for you to reshare your contact information. So if you could share that last screen while we answer questions, that would be great. Another question I have in the queue is, and I'm not sure I understand this question, so I might need clarification, but does your program also include patients who have behavioral health disorders?
So I'll jump in first, just to say that we do provide co-management of mental health disorders in addition to substance use issues. So we have 3 psychiatric nurse practitioners on site, and they co-manage anybody who is diagnosed with a mental health disorder in addition to the addiction substance use disorder. Does that answer the question?
Yes, I think that makes sense.
Thanks.
And then finally, from Syra, she's wondering about any evaluation needs that either OBBO or CompDrug or Columbus Public Health might have to potentially get a better understanding of any quality improvement efforts or scale up, or maybe even statewide dissemination.
So we're currently working on that in our OBBO work group. A big focus of this year is on evaluation of all of the projects, not just the project at CompDrug. So that is our hope, and that is what we've been working on this year.
Great, thank you. I think your program numbers are really impressive, and I know, Jo, that we've talked to you multiple times before, but every time I see those numbers, I'm kind of flabbergasted.
Yeah. Thank you. It's, you know, it's really, after doing this work for a long time, it's really rewarding, and I've learned a lot, and it's really feel good work, to be honest. So I hope that more people get the opportunity to do it, because it's really a lovely partnership.
That's fantastic. So again, I really appreciate your time. I I'm going to move us along so that we get to our last presentation. So I will have Brittany and April get ready to present, and you can go ahead and share your screen whenever you're ready.
All right. Can you see it okay?
Yes, we can see your slides.
Awesome. All right. Good morning, everybody. My name is Brittany Flory. I am a public health nurse here in Cuyahoga County Board of Health. And so I do our family planning with our nurse practitioners we have on site. We do just 2 days a week here serving. We have a West Side clinic in Parma and an East Side clinic in Warrensville Heights. And so I've been here for about 1.5 years, but I've been in the family planning field for about 9 years and truly love the work that we do. April?
Hi, this is April Vince. I've been with the Board of Health for, 21 years now this October, which flew by. And I work in the OUD field, so I'm a program manager for our federal cooperative agreement with the CDC, the Overdose Data to Action. But I've been working in this field of OUD and SUD for about the past 4 or 5 years through another grant before this one through the state of Ohio. So we're very happy to present the work that we were able to accomplish a few years back. And my background is mainly in social work and psychology. Next slide. So the pilot project started at the Cuyahoga County Board of Health, which we have roughly around 150 employees, I believe at this point, maybe a little more. Started in 2016, and it started within our clinic establishing a relationship with one of our recovery houses, and that recovery house is called Edna House. So Edna House partnered with our Title X clinic that's housed within the Cuyahoga County Board of Health. Next slide, please. And as you all know, these are just some facts that were previously reviewed. Women with opioid and other drug addiction often have misconceptions about birth control options and other health plans, which we know this can lead to a higher rate of unintended pregnancies, higher rate of STI, and also cervical cancer. Next slide.
So sort of what we did for our program is we would go in and we would do an educational session, usually the week before we would sign folks up to come in to our Tuesday clinic. And so we always wanted to address birth rates and outcomes for women in addiction, birth control options, education on sexually transmitted infections, and also talking about healthy relationships. We know that these women come from many different backgrounds and we'll never know their full stories. And it's so important to meet people where they are. In that day and that moment. And so after the sessions, it would usually last about an hour or a little bit more, just depending on group discussions, sometimes 2. We would give them the option to sign up for services, including testing, well woman exams, and birth control here at CCBH. When we worked with the Edna House, things have been, of course, been put on pause due to COVID and a few other things, but they had their own transportation. And so they were able to transport their residents to us here in Parma. And so we were working with other organizations in 2019 where they had their own transportation, but we also would be able to provide transportation for them as well through other grant options as well. So sort of what happened during our group sessions, we would talk about educational, and then our appointments would occur monthly, is how we did things. So we'd typically go in Thursday before. We try to be as informal as possible. We know that a lot of these residents are already in, structured classrooms and going to different types of meetings and things like that. So this is meant to be informal, meeting them where they are in their age groups of 18 to 60. We do a 3-part session introducing why they're at risk, going over PAPs and mammograms, and then birth control. We always want to make sure to do LARCs first, just because those are the most effective and long-term. And we know that a lot of these residents and everything come in and out of care very frequently. So that way they don't have to think about their birth control options, but we also carry everything except the birth control PAPs so if they wanted the maneuvering or pills and different things like that. And then also doing HIV and Hep C rapid testing too. And we also can refer for treatment if they are Hep C positive or in the past positive as well. And so they can sign up, and then they would come in Tuesday mornings for appointments. We would specifically block off that time. Our clinic on Tuesdays doesn't start until 12. And we usually would have 6 women at least, if not a little bit more, come in. And so grouping appointments also provide support for them. We obviously have not been doing group appointments due to COVID. That has changed many things, properly spacing. And we also have 3 rooms that we can run if we're not doing immunization services at that time. And we have a lot of referral services in place if they need for different things. We do not have anyone here for like psych care, anything like that, but we do have referrals in place in the communities for East and West Side if they do need a referral for those types of services. April?
Sorry, I was on mute. So just some data that we were able to collect from our 2018 pilot. We were able to educate a total of 65 women. 35 actually came to the office for a visit, which 25 received the HIV rapid screening. 33 received the chlamydia and gonorrhea screening, and then 32 opted to come in for a well visit, which included a pap smear that we were able to provide for them through the Title X clinic. Through our interview process, we did learn that 37 reported a history of sexual assault. 70% sought the LARC choice for birth control, and then also was able to screen for Hep C, as Brittany said, and referrals for mammograms, HPV vaccines, Hep A and B vaccines, and then preconception counseling and prenatal vitamins.
And another part of what we can do is we have an immunization clinic that typically runs 5 days a week. So we're able to get them up to date on vaccinations if they are interested and whatnot. And we also did some outreach for Hep A vaccines last year whenever we had the outbreaks going on. So those are additional services we're able to offer. So in 2019 and 2020, we were able to expand a similar model to another recovery facility in Cuyahoga County and run a few clinics in the similar sessions. And then we've been able to expand education services specifically to other recovery facilities in Cuyahoga County. And we have seen actually quite a few returning clients. We're actually to the point now where we've seen 187 patients through this model. And we have quite a few that have come back for repeat PAPs, mammogram referrals, just general testing and well woman services as well. So they're awesome. We love that they're able to come back, and it's really nice to see some of them have sort of like graduated out of the programs and they're recovered and they're, you know, living lives and everything like that. It's really nice to touch base with them just to see how things are going. So it's really awesome to see their stories after things have, what they've been through. So some of our future steps, we want to obviously to continue to provide education and testing and appointment referrals for women at facilities and adapt the needs of change. I think Joe did a great job of explaining, like, you know, talking through with patients, we don't know what their triggers are going to be and things like that. And we've talked about sort of changing how we do our interviewing process as well, just to gather more knowledge of what we can do for them. You know, healthcare barriers, we don't know where people come from. So we always want to just meet them where they are in the best possible ways. And then we would love to expand to greater Cleveland areas and maybe even add in another clinic day in April, I think, for CDC funding.
And to that point, we all know funding is always ever changing. So we will be trying to secure possible support through CDC in the future. We don't know if it's going to be through the current OD2A, a cooperative agreement that we have currently, or another source. But we are exploring options.
Great. And there's our contact information. We're happy to answer any questions there might be.
Great, thanks. I do have one question in the queue. What types of SUD counseling does your program offer? I guess at the recovery house, like what did those patients, what type of counseling program did they have before? I'm not sure if you can answer this question.
I'm not sure entirely what types of counseling programs they had at their facilities. We don't do counseling services here at the Board of Health ourselves, so I can't necessarily speak to what they're doing. I know that a lot of the patients that we've seen were like inpatient staying at the residential facilities. So if that sort of helps answer that.
Okay. I'm just gonna, if the person needs a clarification, I'll ask. But right now I don't see anything.
Okay.
So can you tell us a little bit more about like the structure of your education program? That sounds really interesting to me. I know that you highlighted it that you like to keep it informal, but like how long does it typically take? And do you make sure you cover the same information each time, or is it kind of flexible depending on the facilitator?
So it sort of is just dependent. So we try for about an hour or so, and we want to make sure that we're covering definitely like importance of well woman, STIs, birth control, and healthy relationships. And that can sort of be flexible, like depending on age of crowd as well. Like we've also talked a lot about like menopause and things like that. Our nurse practitioner, Alyssa, has been able to come to some of the sessions to answer more of like the clinical based questions and things like that. And we try to keep it more to the informal side of things, just because then it creates a more relaxed environment as well. People seem to open up more with, you know, better in-depth questions and things like that. And I feel like in classroom type settings, like I never want anyone to feel like I'm lecturing at them. Like they have so much structure and everything else already that I just want to come in with, here's the knowledge that we have and answer any and all questions that they have. So
that's great. So I have an attendee who raised their hand, Susan Givens. If you want to unmute yourself, you have that ability if you wanted to make a comment or ask a question.
It was actually a question. I just wondered if we could see that contact information again for April, Brittany.
Okay. Sure. 1 second. There we go.
Great. So I have another question while we wait for people's minds to, I guess, digest the information, because we have 12 minutes before the scheduled end time. Do you, at the Board of Health, do you have plans to work with any treatment facilities? And if Alex from CompDrug wants to chime in, I've been really interested about integrating services at treatment facilities or like even detox facilities. How feasible do you think that is from your perspective?
So we've, my supervisor and I have actually talked with some other folks. There are some models we've seen across the state where like myself as a nurse and the nurse practitioner can sort of like rent a space, if you will, in an MAT facility and like combine services that way. And just sort of knock it out that way, which I think would be awesome. And I've heard some models across the state doing that. I can't remember off the top of my head, but I think it's so great to combine services. And it sort of speaks to like what Columbus Public Health has like answering all those questions for folks and everything like that. Like they're doing an awesome job. So we would love to. COVID has changed a lot of things, to say the least. So.
Okay, thanks.
Well, and so Anne, you said maybe Alex could jump in, so I will. I just cannot reiterate enough how I think important this has been to be able to co-locate these services. The moment the service is somewhere else, the percentage of that patient following through drops enormously. So we've seen that during this time, unfortunately, because we've been out of our facility due to that water main break. So we had that, and then immediately after we vacated the facility, we then were hit with COVID. So obviously in these last few months, we've had to make some adjustments, and the interim solution was, okay, if a woman asks about the women's health clinic and our CPH colleagues, we will provide contact information. We'll get them connected to their location on Parsons Avenue, and we'll try and get them over there. And to my knowledge, and Joe, pipe up if I'm wrong, to my knowledge, none of our patients followed through with that. Whereas they would have if they could have just walked right in on site that day. So it's just incredibly important.
We've seen a couple, I would say probably 2 that were coming in for follow-up injection.
Okay, so
we haven't seen anyone new, and we haven't seen anyone for any other care. So I would agree with you.
yeah,
Okay.
I mean, I'm just so excited to be able to get you back on site so that we can keep working on this. And I do think, April and Brittany, to the 2 of you working in Cuyahoga, I think it also really depends on finding a good partner. So, you know, we were primed and ready. We wanted somebody on site providing women's health services, and Columbus Public Health was primed and ready to do it. And that's why this has worked so well. And then we had this great unifying organization that serves across the city with the same interest as well. So we could bring all of us together with the same goal that here's what we want to have happen. And I will say internally, it took a lot of work on my part and a lot of work on Joe's part to get our staff there. I think our staff, and I don't think this is unique to our drug treatment center, a lot of staff who work with people struggling with substance use disorder also have mistrust of other healthcare providers because of all those stories like Joe mentioned from our patients. So we have distrust as well as, I think, a professional body working with these patients. And so there's work that has to be done to help the staff get on board to form that partnership.
That's really good insight. Thank you. A question for Karen, just because you were talking about referrals and handoffs. What do you have any ideas about how the referral system can be more efficient? If it's actually best to co-locate services, and a program might need an intermediary where that is just not logistically or politically possible. What can we do from a provider standpoint to ensure that the referrals, to close that loop on the referrals and do any additional follow-up? Do you think it would be better for the substance use treatment or recovery center to do it, or the reproductive health services provider to do it?
Hi, can you hear me okay?
Mm-hmm.
Good. Well, that's a great question. I think there's probably more than one way to achieve some success with this. And I have brainstormed ideas, but haven't, collected data or implemented anything on this. But some of the ideas that I've had is if you have someone, for example, perhaps the nurse practitioner or a nurse or representative from the clinic that's going to be providing care, going into and visiting the centers that are referring care so that you get some actual face connection, and maybe even those people are doing the screening. So for example, using the Crossroads example, I have considered if we had our nurse go out into the community, into some of these other sites like MAT programs and other recovery programs that don't have the integrated clinic, but that you go out and you do the screening level using something like One Key Question, using that screening conversation, and then they've kind of met you and bringing some materials or something to kind of show them a little bit about the services you provide, and having it be an ongoing relationship. So the client who's considering coming to you knows that you do this a lot with that program, knows that you already know that they're in recovery. They don't have to get through that gauntlet. I think those warm relationships are essential. And then doing simple things like actually helping them make the appointment. You know, we do that in the hospital at discharge a lot. You know, some people need to actually just get the appointment made with help and support so they know exactly what date, what time, and everything. So some of those logistical supports too. Does that?
Yeah, that's that's really helpful. Those are great suggestions. So I will just wait a couple more minutes to see if we have any questions. I will share my last slide and just say that our next session is October 21st, and we will be highlighting initiatives or interventions at community settings, including the justice, criminal justice settings. So look forward to that. And I don't see any more questions, but I would like to just thank our presenters today. I have all of their contact information, so if you need to get in touch with anyone, just let me know. And I really appreciate all your time. Thanks so much to our presenters. Oh wait, so, hold on. Oh yeah, someone also said thank you to everyone, so. All right, I will stop the recording and end the webinar, and I will hopefully see all of you, if not most of you, in October.